precision is a barometer, and it also has an OCT to look for the epithelial mapping. And what it does is, this also gives you an anterior, posterior stromal. This is like your MS39, and the posterior map. Very interesting, which most of the machines do. But where it becomes very exciting is when you start looking at some of these maps. The ray tracing is probably one of the most unique features of it. And this is not something which you have seen in conferences, because he's very particular about giving it to somebody who knows a lot about the optics. So it's not something where we very commonly see. So this also takes a little time for us to understand. This is how your ray tracing maps is. But what I like about it is, you go to the pachymetry, and there is your epithelial thickness. This is very important because it gives you how the epithelial thickness is. But the machine also has an internal repeatability thing. If you go to the repeatability there, so you go to the repeatability, repeatability, ray tracing, yes. Let's do the ray. Now this is the most beautiful part for me. It gives you a ray tracing of the epithelium. And what it's trying to say is, the corneal epithelium has this much of irregularities, which is in the diaphragm components. Am I right? That means there is so much of imperfection on your epithelial plane itself. And that's the first component of what you need to treat. And after that,
here it is in this example, it's like 6 diopters.
6 diopters of change. And if you go to the repeatability, you have to understand that the machine does repeatability for every time, so that you are not dealing with something which is not repeatable. For example, the anterior repeatability, 0. How many times does it take the image to do the repeatability?
Well, it doesn't take, the machine takes automatically to acquisition, because this is required, because basically customizing means rely on surfaces. So the machine takes to acquisition, and only all of these parameters that you see on the screen are validated, then the export is allowed. So,
and you look at posterior, and imagine this is a keratoponic eye. So in a keratoponic eye, we have published repeatability of multiple machines. It is very difficult to get a repeatability with plus or minus 1 diopters. Then you have the stromal. Yes?
Yes, the patient can acquire himself. This is a very nice thing. I mean, the machine tells the patient.
But you need to be a little intelligent.
So with the artificial intelligence, it asks the patients to fix in a line, and it takes it one of the most accurate tomographers. So it takes the whole thing in 1 second, and 1 second is enough to the patient to concentrate in the right, and it repeats it again. When it is 0 repeatability, I mean in the same position, same thing, same reading, it means an accurate repeatability, and it checks the repeatability in anterior, posterior, and stromal surface.
And then it goes to the pachymetry. So what are we trying to do is, the most important thing in any refractive surgery when you're doing a customized ablation is the repeatability of the machines you use. If your repeatability is way off 10 to 15 microns here and there, and 6 to 10 microns of epithelium, you are ending up in a disaster, because you are treating a different type of coma, a different type of ablation. So now we know that this patient's repeatability is perfectly all right. Again, I'm sorry, the names I cannot hide because it comes from the software. So this is not recorded, so it will not be used anywhere. So patient confidentiality is maintained. So let's go back to the maps again. So now you have all these parameters here. So this, technically, when I saw this, I said, okay, a lot of machines can do. Of course, there may be challenge in the repeatability, but what is the real difference is when it goes to, it has a complete system to look at the pupillometry. And the pupillometry is probably the most important factor which makes the system work in a different way. Now, we had a lot of discussions about pupillometry. The pupillometry here uses 8 different light conditions, 6 different light conditions. That means you sit on a machine, which is not the same barometer, it is separate, it's called P matrix, and you sit on it and it uses 6 different lighting conditions to assume what is your true pupil size in different light conditions. That's very important because we all have used to dealing with an optical zone which is arbitrary. Oh, I have a pupil size of 5, I will use 7. If I have a pupil size of 7, I use 10. So there is no end to it. So because in India we have very small pupils, but we don't know what is their ideal pupil size. So this takes how many minutes? The whole pupillometry takes 6 to 8 minutes, which I'm very happy with because it gives you a true pupil size for every single patient. So when you have a true pupil size, it will give you a matrix here, which is it's called the P matrix. And this is a live, this is from the cloud, that is you can sit down anywhere you want and do the planning. And you call the P matrix, and then it tells you for your patient, based on that assessment with different light condition, you are having an ideal pupil size at this range. And this is what we are going to do. Now, the pupillometry is then fed, the data is fed into the machine. And then comes a software platform where you add the pupillometry and all the ray tracing platforms you've done, which includes the entire platforms of epithelium, your stroma, your posterior cornea, and then it goes to the planning software. When you go to the planning software, and you go to the planning software, and now you have, this is the planning software. Now you can choose the epithelium of different, very central. Based on your machine, you can choose what kind of epithelium you want to choose, whichever is the thinnest point. This is a stromal ablation. But interestingly here, that's where I think my friends can tell us, your zone is 3.2 millimeters. The question is, and it goes, the transition can go up to around 9 millimeters. And this is a constant gradient. What I understood from his is how the cornea is becoming more regular as you move from the center to the periphery. Now, what does it mean is your zone is not fixed by an arbitrary number of 6 millimeters or 10 millimeters optical laser. It is fixed based on what is your physiological pupil size. When Pooja is operating under the microscope, the machine again alters the light condition to give you a pupil size which is matched by the P matrix. That means it will then try to give so that you are not ablating on a constricted pupil, nor you are ablating on a dilated pupil. You will exactly ablate on that zone which is going, this is the zone where it's going to the macula, and that zone is where it is trying to correct. By doing it, your ablation is lesser, and you are trying to create a much organized way, and I'll show some results tomorrow. And this is a refraction, it is not your refraction what you use on the patient, this is based on the ray tracing, what is necessary to make your cornea more regular. Now, if I go back to, before I do the surgery, we can know how is this cornea going to make it regular. So you have an expected post-op map, and you go to the expected ray tracing. This is exactly how it's going to flatten. Go to the total cornea, the middle. And you can see this is how it's going to take care of it. And what's interesting here is if you go to the, you can see that, if you go to the surgical planning again, you can see that at the end of it, the machine says that I will make your cornea around 44. I'll keep it in that zone. And I will zone is between 3.2, which is something which took a long time for refractive surgeon for us to understand that you cannot, we always made assume that you cannot go smaller. Of course, we have people have used it for a longer time. There are challenges, but this is a concept not based on how the ablation is. This is a concept from your pupillometry. And this is a total which includes epithelium, which is fed into the machine. So, have I missed anything?
I would like to show also how beautiful is the ablation to compensate for the posterior.
Exactly.
Back again to the ray tracing. To
So it
post-op.
compensates for the anterior and the posterior, so that you
see
have
the
one.
ray tracing post-op. Yes. So the ray tracing post-op, if you go to the anterior, I mean we are dealing totally with an irregular cornea, and you see how the anterior will look like, the ray tracing of the anterior cornea. But this is totally irregular, of course. But if you go to the posterior, which is again, to go to the posterior, you have to go to the. This is very beautiful to show. Get down. Yes, display setting. And go back to the posterior and mark it, the posterior. No, the last one. Yes. Yeah, this one. Yes. So, back again. And if you go to the posterior, you will see how ugly is the posterior. Normally, as the classical teaching, the posterior, the keratoconus begins from the posterior surface, and the posterior is so distorted. So if you go back to the anterior, this anterior exactly compensates for the posterior irregularities, so that to overcome the high coma of the posterior, and so to bring at the end, which is the expected total. Can you go back to total? Yeah, to display setting, and negate the posterior, and go back to the total, and you see how beautiful is the total. This is the total ray tracing, and this is based, on something that we have all been taught in optics, the gold strand model. The gold strand model, if you have an ideal eye with that axial lens, that guarantees the central part of the cornea will go to the fovea. And again, you don't need any large pupil for that, because we have taught from Stills-Crawford effect that the central 2 to 3 millimeters are the most important. So what makes the noxious part, or what makes the classical teaching of refractive surgery to have such big refractive zone and transition zone? Simply the knee, the transition between the refractive zone and the optical zone was just so abrupt. But now we are playing with the gradient. If you go back to the total planning, this gradient, the constant gradient, is just only 11 diopters per millimeter. And I would ask Mr. Giuseppe to tell us about the other machine. What is the gradient for the machine that makes a fixed 6 millimeter optical zone by 8 millimeter transition? It would go to 45 or to 50 maybe diopters per millimeter. So in this lies everything, the secret of the recipe.
Yeah, as Professor Shafik said, our approach is really an holistic approach. So we want to get basically optimized quality of vision, but simultaneously minimizing the sickness. This means that, again, we are not printing a lens on the cornea, but just basically designing the ideal shape, just removing the tissue which exceeds. You know very well that, for example, in a cone, the posterior is bumped. So this means that we do not need to remove completely the bump of the anterior in order to compensate it. And reducing the refractive zone to what really needed to the patient, we save quadratically, because, the ablation is quadratically proportional to the diameter of the tissue. So again, the idea is basically to give, within the refractive zone, limited to what really the patient needs, the quality of vision. But, as he said, in order to grant stability, we need not to make basically a constant width connecting zone, but the connecting zone must change the width in order to grant, again, an homogeneous smooth gradient, in order to allow the epithelium to regrow homogeneously. If we make an optical zone of 7 millimeter, this will mean that we will create, especially consider like an hyperopic treatment. If we make hyperopic at 7, we will make a canyon. We will destroy basically the capability, basically the biomechanical properties of the cornea, and the epithelium, in such a kind of way, will must regrow in order to complete full, basically, the canyon that we are creating. So again, making a very narrow refractive zone and giving a constant, very smooth gradient in radial direction, it will allow the epithelium to find an homogeneous effort to regrow in an homogeneous way in all of the radial directions.
And you can see that the transition zone is different in different size. That allows to heal the epithelium. And if you go back to just go back to the epithelial maps, it's very important because you've seen that we have, go back to the epithelial ray tracing, the pachymetry, because this is important because whenever you do any type of refractive surgery, especially the topo-guided or recorrection, the major component of refractive surgery happens on how you remodel the epithelium. And pre-op, if you look at the pre-op pachymetry, and look at the ray tracing of the epithelium, and you can see that this ray tracing of epithelium has so much of imperfection in here. This is keratoconus 1. That is one of the challenges why we have a lot of challenges in doing a perfect topo-guided treatment, because we not factored in how the epithelial ray tracing happens and how it has an impact on the healing. But if you want to see what would be the predicted outcome after you're done with the treatment, we have to go back and just look at the predicted post-op ray tracing of the epithelium, because, and in my limited experience in a month, it closely matches to what he says. In fact, I was not a believer. And look at this. The same epithelium, this is modeled into the factor. It's the same epithelium, and the 3 patients which has finished 1 month closely matches to what it predicts. That means you could see that the patients were having in this zone. Unfortunately, you should have something where I can compare both the patients. The software doesn't allow to compare. So that will be easy to explain. So what you see is, you can see that there were more than 6 diopters, 4 diopters, 3 diopters of ray tracing change. Now, all of them are between 0.4. That means you have modeled the cornea in such a way that you're creating that impact which is going to change with the epithelium. So what I understood from this whole concept with my limited understanding is, if you look at the whole model, I was told it can also do that because it works on scar correction also, and there are a lot of other factors which can do it. It also has a inbuilt, you can feed the axial length, it can give you a lot of new ways of angle calculation which you can discuss with him during this next 2 days which he's going to be here. If you go back to Ashish, ready?
If we are ready, can I give
Yeah,
it's a total paradigm shift in our thinking, because it's very hard for any classic refractive surgeon, all of us, to imagine that with 3 mm optical zone you can correct that. But imagine that it's a total ideal shape is defined by the ideal shape of the cornea that will deliver in this point the ray to the fovea, okay? And this ideal shape is defined easily as this, by taking the excess, not imprinting a lens on the cornea. So if you're taking the excess from the irregular tissue, you're actually doing a fine tuning on the cornea, taking very little tissue, and if you tailor the optical zone to a very small one to refine the beam, the light beam to fall on the fovea in the central 2 or 3 millimeters, this will guarantee you a more or less.
I think we'll move because the patient has been waiting for some time.